what I'll do is just tell you a little bit of history for us, and that is some of the data that Lisa was talking about in terms of access data, that generally the Latino community has had very poor access, and that they're a rural population oftentimes or in urban areas. And 2 years ago, we partnered with the Office of Rural Health. They have a farm worker health program that's around the state, and working with truly the one, a population that is so vulnerable and so has such low access to healthcare, and that's the migrant farm workers. And we saw this as an opportunity to partner with them to not only do integrated care in the farm worker health practices, but also to do video practices, which is something that we've flirted with and worked with for a number of years, but have really always struggled to make it work. And we've worked on that for the last 2 years, and we've done it very methodically and deliberately and rather slow, but I think intentionally going slow to make sure our methodology was good and train the right staff and have a brief intervention strategy. We're humming along, and in February we had 319 people were seen through that program, and then COVID hit. And as many of us have experienced, it just kind of blew the doors open. John said this earlier, that it really did revolutionize in his opportunity, but wow, we had close to 2,000 people in April that we served through, or encounters that we had through the video technology. So we needed to stop and check ourselves and understand, what is this? What is happening? Is it appropriate for this community? Yeah, we're coming in with a new instrument, something that we think is good and we're intending to be good, but is it really helpful? So we've done a survey, and I'll show you just some preliminary data. This is from 808 patients that we saw in the month of April. And then in that time period, we surveyed 204 of those who were Spanish speaking. These were the people who did have an appointment by video. And you can see here the preference of people. When we asked them, well, what do you prefer? You've had this video appointment, but what do you prefer? And what, by and large, you can see generally everybody or many people preferred the in-person appointments, as opposed to the red bars, which are the video appointments. And then some people said, well, video appointments until COVID's over, and then I'd like to come back in person. And some people said either. But I was kind of surprised by this, that this many people were ready to get back in person. And I thought, oh, but it's really connecting well. But truly people were saying, I prefer in-person appointments. Then we wanted to look at subgroup analysis and say, well, is this US born versus foreign born? And you can see there that there's not much difference. And this hasn't been yet analyzed strategically or statistically. We're doing that right now. And then another question that was very quick was, well, is this based on education level? And we didn't see much difference there either. So we're continuing to look at this data and try to understand as we move forward, does the video technology get in the way? Does it help? Is it certain populations that it's helping with? And also, we did this right in the midst of shelter in place. And what will it be like when we do it again, which we intend to do in June? And then when we do it in October, and we can kind of watch that. So the first thing is to go and ask people, how is this affecting you? And that's what we're finding so far. And then what are we seeing on the ground in the trenches? This is where I'm most comfortable. I heard I've continued to hear through the morning policy and high level thinking, and I appreciate so much people who do that. But I'm definitely in the trenches doing just clinical work. We also have a network of providers around the state that we are in community with, about 700 in a network that we formed around Latino mental health issues. And we get feedback from them. We've been on many calls this week and finding out, well, what are you hearing? So here's what we're hearing. Here's what we're seeing. First is people saying, I just need to get back to work. I heard one man just recently who said to me that this is a virus that is a conspiracy against the Latino community to keep them out of work and keep them down. But in general, people are saying, I need to get back to work. That is a priority in my life, and it's economically something that I have to do. So we're hearing that pressure from people, and people who've lost jobs who are looking for jobs now. Somebody said this week, that the children who are socially anxious are loving it right now. And I've seen that too. I've kind of seen two tracks with the children that I treat. Some are actually doing great. They're gardening. They're going on walks with their family members. They're smiling for the first time and they're not feeling the stress of school. While there are others who are not loving it. Some who are very isolated and non-stimulating environments. They're recessed. There are some who are anxious and perfectionistic, who now they are not in a classroom situation where they can raise their hand and get the attention that they need and ask for help that they need, and actually having trouble with technology, which I'll talk about as well. A lot of the behavioral health providers we're talking with, and I just talked with UNC outpatient yesterday, and they said the same, that they're getting great numbers in terms of engagement. We saw our productivity numbers around 100% during the month of April. Very robust. Even 1 week after we closed our physical doors, we all of a sudden we're still seeing 100% of our productivity expectations. People are seeing that, but the nuance there is that there maybe is low family engagement. And what I mean by that is that it's really hard to engage these young children on the video. It's hard to keep them engaged. That it's a desperate time for families, and they are having to scramble and find resources. And it's really hard for a lot of these families to connect internally and then be involved in the mental health treatment process. So that's been a challenge for us. Another thing we're hearing is that it's this late in the game and people still don't know where to go get a mask, and people still don't really understand the public health message that we think is so ubiquitously out there. And so that's very concerning that we're this far in and people are still asking questions that make us stunned that they may not have access to the information we think is just available. Many of us are worried about transition periods as people graduate from one school to the next or make transitions in their life, that this is a time when physically they're together. There's a lot of events that memorialize that, and a lot of social events that memorialize that in a way that is not available right now. And then juvenile justice youth that we deal with and our partners deal with are, in essence, running amok, is kind of what I've heard, that they're on the streets, they're not taking into consideration these precautions, they're not getting good supervision, and they're having an exceptionally hard time right now. And then the technology barrier that we have already seen has gotten worse as we start to push more interventions and more communications through technology and not through other methods, that is becoming a bottleneck. And so I have a school bus on here. And the reason why I have a school bus is because in Charlotte, Mecklenburg County, I heard from one of our partners this week that they are putting hotspots in the buses that aren't being used by the school district right now and parking them in the low resource neighborhoods so that those kids can have access to the internet technology for their schooling. And there's many others in Wake County innovative approaches that are happening that I'm hearing about. And I think that's wonderful, but we still are having to remember that technology is a significant barrier. Still at the ground level, let me take you one more step and just say, and I think I've got a few more minutes, but I'll just go with this last slide here. And that is, what is it like when we reach out to speak with somebody and interact with somebody who is one of our current caseload or a new person coming in? Well, usually they're coming into the office, they've sought us out, or we're going to them in their home, and we have this connection, and that's access, and we've learned how to do that over the years. Now it's different. I'm having to work with our clinical staff and with our administrative staff, and the very first thing is, can we reach them by phone? So I mentioned the survey that we did. We had 204 responses. We had a crew of people who did this. And would you believe that the most successful person who did our survey was actually the person who does our cleaning at our clinic. She obviously is not being able to clean right now, so we put her to work doing the surveys. And she was the most successful in reaching out to people because of her experience as a manager at a hotel doing cleaning service. She knew how to find people at the right time and talk to them in the right way. The people who are not so involved in that kind of industry, and I'm referring to some of our South American people who were not as connected with maybe the Latino Mexican community didn't understand some of the nuances. And so reaching out by phone, they would call me back and say, I can't get anybody on the phone. And then the lady who does the cleaning said, I just did 30 surveys. Can I do some more? So it was really amazing to see that, just very significant. Just reaching out by phone was difficult for some people, and how to reach out by phone and how to engage people was as an art. And then we didn't go straight to, do you have a video? But we said, okay, now we need to ask, do you have food? Are you healthy? And do you have a mask? So that's what we're asking. Instead of getting right to the point of behavioral health, we're going to these other issues that are so important. And I have over here in Spanish, ¿tienes suficiente comida? And I showed this to a staff member a little while ago and said, make sure my Spanish is good when I put this out there. And she didn't correct my Spanish. She said, your Spanish is perfect. But she then said, you may want to also ask, depending on your context, does your family have enough food? And do you have the virus, or does anybody in your family have the virus? Do you have a mask? Does anybody in your family have a mask? So very much a family, broader communal orientation is important for us. We have to keep reminding ourselves of that. And then now let's ask them, well, can you do video technology? And how can you do that? Well, a lot of people want to do WhatsApp or Skype or something like that, and we're preferring a technology that could stay with us long term. We're using Zoom with HIPAA and with the data encryption, and we want to use that. So now we need to coach them through that appointment and get them into it and get them connected. And finally, we're able to say, how is your mental health? Or in Spanish, we would not say, how is your salud mental, because that may have stigma, but we would say, ¿qué tal está tu bienestar emocional? How is your emotional well-being? So those are just some ground level perspectives. I'll end here, and I'm going to hand over to Julius Wilder, who's going to lead us in a discussion now. Thank you.
And Dr. Smith, thank you. You provide a valuable resource, and you highlighted something about Hispanic mental health that I think is a key point, because I think as we've thought about what it means to be in the midst of a pandemic, that we have not appropriately recognized the mental health burden on everyone. And again, those individuals who are most vulnerable will be the most greatly impacted by this. And that comes into play in so many different ways and intersects in so many ways, with our Latinx population. Can you speak to some of the specific issues that you may have seen pop up within the Latinx population in the role that you play? And perhaps also touch on, what we're seeing in that population, relative to being higher in North Carolina, for instance, in terms of the burden of COVID when comparing it to other parts of the country.
Yes, the primary types of disorders that we see already are ones of stress and mood disorders, such as depression, anxiety, PTSD, adjustment disorders, and that spectrum. And that's typical for a younger first-generation immigrant community, that the longer they live here, the more sick they'll get, and then also they'll get some of the more severe persistent mental illnesses. And so then if you add a stress like COVID on top of that, that's threatening the very economic security and education. And I look back at, why do people come to the U.S.? Well, it's around work, providing better for the family, getting better schools for my children. And all of those things have just been threatened within the last 2 months. And it's having a real impact on people. That stress just went way up. So people who already have pre-existing illness have already seen more of that exacerbated during this time, to some nuance, like I was talking about earlier. And that then just the threat of the virus is, at first it was kind of not seen as going to quite target our community. And then all of a sudden it begins to, with community spread. I don't know where I'm getting this. When the contact tracing is done, there wasn't a close contact, and that those community spread rates have gone up so high, especially in the Latino community in the last couple of weeks. And what we're seeing is that the general messages in the media about reopening, and it's all clear, wave the flag, that individuals who are living in multi-family homes all together, and then they're carpooling to work, going to a crowded work factory or situation together in low ventilation areas, and also shopping at small tiendas or stores are especially at risk. And then not to know where to get the mask. That's a very simple thing. It seems, it's like, where to go get the mask? Oh wait, there's no mask. Where do I go get it? So those are the basics that we're having to default to. And as I said earlier, the stress is there, the illness is worsened, but we're needing to go even upstream from that oftentimes and just talk about basics and go back to those initial needs and some of that. So that's what we're seeing in that context right now.
And so when we think about that next step, Dr. Smith, and we think about vaccination and we think about the best way to engage the various diverse communities we have, how do you think is the best way for us to engage our Latino community, particularly in the setting of the stress that already exists and knowing the burdens or the barriers that have already been there in terms of trust, in terms of our ability to appropriately communicate in a language that's appropriate? Could you speak a little bit on that?
Yes, I think I'm struggling with that right now because if I have an opinion, then my patient has an opinion and my staff person has an opinion. And I actually need to be quite humble and thoughtful and listening to all of those opinions. And then at some point I need to make a decision. What are we going to do? And so if the patient is saying, I want to see you in person, they may, I don't know where that's coming from. I need to understand what is that about. And I also need to watch and see how that changes over time. In a month, they may not be saying that, or might be certain people. And I know that we're having a hard time engaging the ends of the age spectrum. The young and then the old are harder to engage right now with this video technology. But then I look at my staff who are listening to the news and they're more informed oftentimes, and they're very wary about coming back into contact with people. And so now I need to think about protecting them and making sure they're safe. And that I just need to keep listening and being dynamic in this process. So I think that's how I'm navigating this right now. And I find myself parallel to a lot of the bigger systems that are doing the same kind of navigation. But I think listening first is key right now to see where people are at. I'm just thankful that at least we're able to still reach out and connect with people. Another part of our survey is functionally, how are people doing, and doing surveys to see, well, but are their symptoms getting worse? Yeah, they can do the technology and they prefer it better or whatever it might be, but they're getting worse. And is that because we're doing it through the technology and we actually need to be back in person because that's a more effective service? So just there's a lot of different variables in there. Those are the ones I'm thinking about.